Monday, I'm here with Dr. Roy Sandberg talking about hip and knee replacement. Dr. Sandberg is an orthopedic surgeon, but this is your jam, is the hip and the knee.
It is.
All right, so I was asking before we went to break about hip replacement, and you said those folks tend to go home pretty quickly. Not a lot of physical therapy, actually, having to go to the physical therapist. You have them doing exercises at home. But what about things around the house that they need to pre-think before surgery?
Sure. Some of that has to do with just being able to do your activities of daily living, we call it. So going to the bathroom, getting things up off the floor in a safe way. We do have some restrictions that we put in place for about the first 6 weeks or so after surgery, just because the hip can be a little tenuous in terms of being stable in the socket. And it's stable when we leave the operating room, but we try to not have huge forces going in awkward angles across the hip because you could pop it out. So the first 6 weeks, we have people just avoid some certain movements with their hip that have to do with how far they bend down, what direction they twist their leg, but they're pretty simple to get to an understanding of, really. But really, most of the time, if people have somebody at home that can help them out the first few days, after that, they're on a walker for a few days, then they go to a cane, and then really just as more they walk, the more they build up the strength in their muscles, and the more they get back to doing the activities they want to do.
What is that time frame when people feel like I'm back to normal?
You know, that varies from patient to patient. There are some patients, I would say more so with the hip, that leave the hospital saying, oh my gosh, my hip feels so much better already.
Really?
Because this deep, achy front of the groin and hip pain that they have after a hip replacement is gone. They have some pain from the surgery and from the muscles in the surgery, but they say it's a different pain. I can deal with this. Knees are a little different. Knees are harder to get over than hips. I tell people, on average, I say it's a 6-week investment surgery, meaning you still have some pain, probably more than you did before surgery. For the first 4 to 6 weeks after that surgery, you're taking pain medications, you're not sleeping that well, but that slowly gets better and better again. The more you go to therapy, the more your body just recovers from the hit that it took in the operation, and the more you get out and try to return to normalcy. By about 6 weeks, I say, though, is around the turning point for a lot of people, where they say, okay, I'm finally coming off the pain meds, I'm sleeping a little better, and my knee is starting to feel better than it did before surgery.
Why the difference? Is it because the knee is involved in so many more movements, or why? Are the surgeries so different?
It's hard to know, because the knee, for some reason, it has a lot of pain fibers in it. Some think, that there's a thought that, the knee being much closer to the surface, people can see it, and it's just kind of a different beast than the hip, honestly. Some of it too is that the hip's a ball and socket joint, which tends to be a little more forgiving, I guess, in terms of the mobility that you need from it. But for whatever reason, the hips just do much better than the knees. Overall, kind of nationwide, the numbers they report that about 95% of patients are satisfied with their hip replacement and say that they would have it again. Whereas for the knee, it's maybe only about 85% of people are really satisfied and say that they would do it again. So for whatever reason, the hip just is much more of a home run surgery usually than the knee.
When you're thinking surgery, you always have to think about complications. What do you warn your patients about?
So, depends differently from hip to knee, but unanimously we warn the patients about the risk of infection. As a surgeon, as a patient, that's one of the more devastating complications that you think about. If a joint gets infected, it's not the end of the world, but it is usually a couple-month process to try to treat that infection. It usually requires at least 1, a lot of times 2 additional surgeries. It involves taking the implants out, putting temporary ones in made of antibiotics and cement, IV antibiotics, and then a second surgery to put a new implant back in once you've cleared the infection. So that's one of the big ones. The other big one for the hip is dislocation, as one of the ones you worry about the most, and so that's why, again, we have people. That sounds
terrible.
We have people avoid those positions for the first 6 weeks or so, but after that, once everything scars in, the dislocation risk is pretty low. I mean, for dislocation, we're talking about 1% or less of all cases, so it's not 40–50% of people that this is happening to. For knees, the most common complication after a knee replacement, I mentioned that 85% that are not quite happy with it. That's the most common complication, is persistent pain after a knee replacement. And we as a surgeon community are really doing our best to research and try to figure out why. I have a patient that it looked like they were a good candidate, the implants look good, the knee feels good, yet they're not happy. And everybody, that's where a lot of the research in knee replacement is going right now, is to try to figure out, you know, how can you predict which patient may not be happy with their knee replacement after surgery?
And just so I make sure I heard you correct, did you say that 85% of knee replacement folks are happy? Is that 15%?
Yeah,
and
so it's about 15 or so percent. And again, that's kind of nationwide. 15% or so, they're not quite as happy as they wanted with their knee replacement.
Okay, very good. Let's jump to the lines. We have Shirley on the line. Good evening, Shirley.
Yes, I have a question about my knee. I have a torn meniscus in each side of my knee, and I want to know if it is more likely, if I don't have it repaired, am I more likely to need knee replacement as compared to if I do have it repaired?
Great question. Will it lead to other things?
So, I guess a follow-up question I would have if Shirley is still on the phone is, Shirley, may I ask how old you are?
81.
81. So,
yes.
I would preface this by saying I would need to see your x-rays, but if your x-ray shows some arthritis, that's really what those meniscal tears are. They're a manifestation of the arthritis. So again, going back to the tire tread example of once you've worn the tread on your tires, you're less concerned with every little flap and crack and tear in the tire tread. You have to think of it as a whole. And arthritis is very much the same. And what we've learned is that if we try to take a knee that has arthritis and do an arthroscopy to fix that meniscal tear like we would do in somebody that's 16, the data has been very clear that it doesn't really offer any long-term benefit. And in some cases, it makes the knee arthritis worse. So for somebody like Shirley, if she was in my office, again, if her x-rays showed some arthritis, I would not recommend an arthroscopy. I would say we try to maximize non-operative treatment if we can. And if that doesn't work, the surgery that she would need would be a knee replacement, not an arthroscopy at 81 years old.
Yeah. Very interesting. Shirley, I hope that helps clarify some things.
Okay, yes, thank you very much.
Thank you for calling in. We also have Richard on the line. Richard, go ahead.
Yes. Let me just turn the
TV down a little bit?
Yeah.
Okay. Appreciate that.
I had a orthopedic surgery October 5th of last year.
Okay.
It was on my knee. It was arthroscopic, and it was for a torn meniscus. Shortly thereafter, I didn't injure it, but just I was on my knees and I got up, and when I got up, I couldn't put any weight on it. I went back to the doctor. Doctor says, you have a bucket tear, and apparently I'm trying to get the bone right. The femur has two knuckles on it for your knee. An outside and an inside. I guess they're called compartments. He said that the compartment on the outside of the knee is tore up. And I'm like, okay, a lot of arthritis. I'm 61. I've been offered two options, actually three options. The first one I turned down was a bone graft by the VA. The reason I turned it down, he said, I'm a bachelor. I live alone. I have no children. I have a 150-pound service dog. We just came in. He told me that if my foot hits the ground anytime during this 3-month recuperation, that I could lose the leg for damaging this graft. I told him no. Now I see another physician, Dr. Cox out of Vanderbilt, and he said, look, I'm not going back in there. I'm referring you to a guy for replacement in our team. I'm 61. I'm not an active guy. The most active thing I do is walk my dog. Now I'm like, okay, do I go with the partial or do I go with the full replacement? And what does all of this entail?
Okay, so that's where we are.
So thanks for the call, Richard. So Richard's scenario is one that we see on occasion. So again, he has more of the whole picture of arthritis, the chunks out of the cartilage that he talked about, again, a manifestation of the arthritis. So I would say what you decide to do, Richard, really comes down to how much pain you have and how your life is being affected by it. If you can walk your dog, without any treatment, and that's what you want to do most, well, then you don't have to do anything. And I stress that again. These are elective surgeries to try to help you be more active and live life more pain-free. That being said, I would look at his x-rays. I would see what kind of treatments you have tried. If he was somebody that really wanted to avoid a surgery, I think that's totally fine. We could work on some home strengthening exercises, maybe do some cortisone injections. If none of that helped, I would offer him a knee replacement based on what he's saying. Again, I can't make the distinction as to whether or not a partial or a total would be better for Richard. I would have to examine him and see the x-rays. But I think either one of them would be certainly an option for Richard if he's really somebody that's uncomfortable and is unhappy with their quality of life.
So Richard, after this commercial break that we'll take in a few minutes, so you've got plenty of time to do this, grab a pen and paper, and we're going to give you the number to call or the emailing if you want to get a hold of Dr. Sandberg and talk about some things and have him look at your x-rays. So you got several minutes to get that pen and paper, but go ahead and do it. We'll be giving out the email and the phone number in just a little bit. Let's talk about revision surgery. I'm sure that comes up from time to time. People have had a hip or knee replacement and it's not gone so well, or there's been additional injury or additional aging. What sort of things do you see with that?
I mean, that's really to a certain extent a Pandora's box. I mean, it can be anything. I mean, it can be anything from just the plastic component in between just wearing out over time, and so we just need to go in and replace that piece of plastic in a hip or a knee, and then that's it, to everything from, you know, a big process where bone is lost and is eaten away, and you have to use much different implants, much bigger implants. It really runs the gamut. In terms of the knee, we see everything from components that have come loose from the bone, again, bone loss, infections, and sometimes where the ligaments or the tendons are torn away from the knee and you have to try to reconstruct those or put implants in that actually interlock one with another to provide that stability. So it really runs the gamut of what you can see and really what we can do. But that's part of what we're trained to do. You know, sometimes in the bigger revision cases, you're putting in a whole piece of metal that takes off the top half of the femur. You have to replace all of it because it's, you know, the bone has been eaten away or there's some kind of a problem. Same thing with the lower half of the femur in a knee replacement. Sometimes after several revisions, if there's just not a lot of bone left to work with, you have to replace it with metal. Actually, in Nashville, there's a very famous implant that was developed actually here in Nashville by the gentleman at Southern Joint Replacement that dealt with big bone loss problems in the acetabulum, and every once in a while you have to get really creative like they did.
Wow, that's very interesting. How long are these prosthetics made to last?
Another good question. So more modern parts, for example, the knee, we're seeing 95% of the knee replacements we're putting in are going strong at 15 years. And so that doesn't mean at 15 years, oh, they all start falling out. Most of them are still in the patients and don't show any signs of any adverse wear or coming loose from the bone. Hips, they're about 10-15 years ago, we redesigned, not we, but the biomaterial experts did some different things to the plastic liner. The plastic liner that we used to see, it used to make a lot of debris, and that would cause a big inflammatory reaction that would eat away the bone. But with this newer polyethylene, which is the name of the plastic, we're starting to see a lot less bone loss, and we're seeing the hip replacements just lasting longer and longer. And even if you do have to go in and replace that piece of plastic, you're not dealing with the bone loss issues that we once did. So it's definitely getting better as our materials have gotten better and as we understand the processes that led to the destruction of the bone. Thankfully, we're not seeing as many of the big revisions with bone loss that we used to.
When you have a patient come in who is 40 or in their 50s, do you have different conversations with them because these are not made to last 40 years on what to do? We
will have different conversations a little bit. I think at that point, you know, if I have a patient that's 45 or 50, you know, I talk maybe a little bit more about the longevity of the implant and the possibility of a revision down the road maybe than I would for somebody that was in their 80s. But that being said, if they really are at the end stages of that disease, you know, they're not going to want to live the next 20 years of their life in pain just to avoid a theoretical revision down the road. So it becomes something that you deal with that scenario and you say, okay, down the road, when and if that problem comes, well, then we handle it. Sometimes there are, slightly different modifications in the implant and choices that you might make in a younger patient in terms of your bearing surfaces or in the knee, whether or not you choose to fix them to the bone with cement or with an implant where the body can actually grow into it. That's kind of an emerging area also to see what type of implants really work best in that younger patient.
What would you tell the person whose hips and knees are great right now and they want to stay that way? How should we treat our bodies to avoid leading to a hip or knee replacement?
So my mentor in fellowship, Dr. Meneghini, he used to have a saying. He said, nobody over 40 should be running.
Oh, no.
So he said, and now there is a little bit of data that's come out that says, well, maybe running wasn't quite as bad, but we know that the loads that you put on your joints when you run, they're about 5 to 6 times your body weight, and it's the repetitive impact that seems to not be beneficial for your joints. So I would say,
it makes sense.
If you're a runner, the best thing is staying active. So if you're a runner and you love to run, I mean, keep running. But if you could make yourself switch to something like a bike or swimming or doing some of these mini triathlons that some of the endurance runners, that's what we try to get them to switch over to. But really it's just about being active. Your joints like to move. They like it when the muscles around them are strong. I'm a big fan of these dynamic exercises where you strengthen and you move at the same time. So things like swimming, where you get the resistance of the water, that'll build some muscle up. Things like stationary bikes or even regular bikes, and then elliptical trainers, I think, are all really good. They're good workouts for both the hips and the knees.
Okay, good information. I'm gonna take it to heart. We have Deborah on the line. Deborah, are you with me?
Yes.
Hi there. We're running against the clock, so go ahead and ask your question. We may have to answer it after the commercial break, but if you can be quick, that'd be great.
Yes, like I was explaining to the lady, I'm 55 years old. I've had 3 orthoscopic knee surgeries. One is bone on bone. One now is lower cartilage. I can't do cortisone shots because they don't help. And I'm diabetic, so what am I to do?
Okay.
Okay. So diabetes in and of itself is not a contraindication to having a knee replacement. And I think that's something that we have to understand. Again, with this being a quality of life surgery, it is something that we all have to just be on the same page with what the risks are. And the risks in a patient that has diabetes that's really well controlled, your risks aren't that much worse than a standard patient. So we don't need to withhold that joint replacement from them as long as they understand maybe they have a slightly higher risk for infection. If they're willing to take that risk, and we can modify it as best we can, if we can get their blood sugar a little more well controlled and get it back down to a normal level, they have very good outcomes. And there's some different things we can do as surgeons to try to help with that.
Good deal. Deborah, I'm glad we got in your call. We're going to take a quick break and we're coming right back.